are in listen-only mode.
Good evening. I'm Phyllis Loveland, HHT's Communications and Operations Manager. Welcome to our virtual meetup, Ask the Doctor, Nosebleed Management 101, with Dr. Scott Olitsky and HHT special guest and patient advocate, Chelsea McBride. So before we start, we have a little bit of housekeeping to take care of. Unlike most of our virtual meetups, this one will be recorded, so you'll receive a link after the webinar, and you'll be able to rewatch anything that you missed or share that link with family. We're also going to try to get through as many of the questions that were sent in advance to Dr. Olitsky and Chelsea to answer. Any of the ones that aren't able to be answered this evening, if we run out of time, we will try to follow up with an email directing you to resources on our website that can help you answer those questions. And we've also muted everyone's phone or microphone just to eliminate any background noise. So let's dive in because we have a lot to go over tonight, and I know this is a very popular topic, so I want to introduce you to the host of our Ask the Doctor series, Dr. Scott Olitsky. He's HHT's Chief Medical Officer. He's a member of the HHT Board of Directors. He's a retired pediatric ophthalmologist, and he's also part of a family with known HHT going back 5 generations. He's co-hosted tonight by Chelsea McBride, a patient and advocate for HHT, and for those that follow along on our Facebook pages and Instagram, if you're popping on there periodically, you'll see Chelsea coming on to provide resources from our website, answering questions, and providing helpful suggestions using her own personal experiences with HHT. She graciously agreed to co-host this evening to bring a patient perspective to tonight's content. So I'm going to go ahead and punt tonight's program over to Dr. Olitsky and Chelsea.
Excuse me. Thank you, Phyllis. And I want to thank Chelsea for joining us, and I'm really looking forward to her perspective. I'm sure many of us will have a lot to learn from what she can tell us about some of her history and what she's done with this all too common problem that we all face. So I thought I would do a general short overview of epistaxis or nosebleeds in HHT. I don't plan on getting too in-depth on any one topic, but wanted to kind of go through a number of treatment options that many of us have probably tried, some that we probably have not, and maybe at the end I'll touch on the potential exciting new therapies that we may have in the not too distant future. So we all know that nosebleeds are the most common manifestation of HHT, and back in 1865, Dr. Babington actually was the one who reported on a family of 5 generations who had significant nosebleeds. About half of the family members were involved, and this was the first report of what we now know as HHT. So the disease was originally described based upon the hereditary nature and the significant epistaxis that occurs in HHT. As you may know, it's common. It occurs in about 90% of people with HHT, so not everybody with HHT experiences nosebleeds. Some patients with HHT have very few. Some obviously have significant life-threatening or life-altering manifestations of their nosebleeds. But about 10% don't experience nosebleeds. Of the 90%, generally gets worse with age. I think most of us can attest to that. But 10% of people will have little or no degree of nosebleeds. And this is important to know because sometimes, especially in families with HHT, the lack of nosebleeds in a family member can lead them to erroneously conclude that they don't have HHT. And we know that 1 in 10 cannot. So the fact that a family member does not have nosebleeds by no means eliminates the chance that they have HHT. In addition, the extent of nosebleeds does not at all correlate with the systemic involvement of the disease. So you could have little or no nosebleeds and have significant AVM formation in other organ systems, or you can have significant nosebleeds and not have any other effect from HHT other than your nosebleeds and perhaps anemia associated with those nosebleeds. Why do they occur, and why is it such a common problem in patients with HHT? Well, we know that these telangiectasia, these abnormal blood vessels, and the telangiectasia form between a vein and an artery with no intervening capillary process between those two. And we know that those typically occur in large organ systems and also on mucosal surfaces like our tongue, our lips, and certainly in our nose. The nose has a very rich vascular supply. It's designed to warm the air that we breathe, so that's why we tend to see telangiectasia form there. There's a large amount of blood vessels. And one of the things we've learned is that telangiectasia tend to occur in areas that that experience trauma, and I have trauma in quotes there because the type of trauma may vary. We see telangiectasia occur on fingers, for instance, probably just from the trauma of day-to-day use with our fingers. The thought is that the air that flows through our nose, that there may be disturbances in the airflow which induce this trauma to the nasal mucosa, and these lead to the production of the telangiectasia in the nose. The telangiectasia are fragile because there's no capillary system intervening. They tend to bleed easily because the high pressure from the artery connects directly to the vein, which should not be receiving such a high pressure. It's usually modified through the capillary system. So they bleed easily. Touching your nose, manipulating your nose, certainly people know that blowing your nose, all of these things can easily induce that trauma to these blood vessels in your nose that will make your nose bleed. Another important factor we think is that drying of the nasal mucosa may also play a role in bleeding by irritating these blood vessels and causing them to bleed. I'm just going to touch on a couple of points here because I know Chelsea's going to speak to a greater extent about some of the methods that she's found to be helpful in stopping a nosebleed. But in general, I think about these in two categories: the home remedies and the treatments where you're going to have to seek medical care. And home remedies may involve something as simple as placing pressure on your nose to avoid the bleeding or decrease the bleeding until it stops on its own. Packing your nose with some type of material, whether it be gauze or cotton or tissue. It's important to use materials that don't stick to the surface, because I think most of us know that once you put something in and it stops and then you pull it out, it tends to tear away that developing scab or blood clot, and your nose just bleeds again. So some people find it helpful to put an ointment on cotton balls before they put them in. There are other substances, medical substances that you can obtain from a doctor's office, and some that can be found over the counter at drugstores that eliminate or at least decrease the chance that you're going to have the bleeding start when you remove the packing. As I mentioned, there's medical grade packing that some patients get from their physicians. Treatments in medical facilities might include these balloon devices where they go into your nose and a air pump is used to balloon them. It might lead to less trauma to the nasal cavity. Disposable packings that are placed into the nose and dissolve over time. Emergency cautery might be an option. We'll talk a little bit more about cautery, something we try to avoid for the treatment of nosebleeds and HHT, but if a patient's in the ER, this may be an option that needs to be available for them. And lastly, again, I'll mention a little bit later, emergency embolization. We usually don't embolize the arteries leading to the nose because it's a temporary fix, but for some life-threatening nosebleeds, it may be a very useful and even life-saving procedure. Well, I guess the best way to stop a nosebleed is not to have one to begin with, and it's probably not possible for most of us, but ways to potentially decrease a nosebleed include these three things, I think. Moisturizing your nasal mucosa surface, some medications, and potentially surgery. So moisturizing is certainly in many ways the simplest and easiest thing to do. a humidifier in the house, whether it's placed in a room or you have a system-wide humidifier, is helpful, especially for those people living at high elevations, dry climates, people living in indoors with forced air heating, which tends to be very dry. I recommend getting a humidity meter. They're relatively cheap. You can purchase them online, and they can allow you to monitor the humidity in your bedroom and your house. But this is a kind of a first step I think most of us should be thinking about. Sprays, where you spray inside the nose to keep it moist. You have to be careful because some of these sprays actually have a drying effect once they evaporate, and they may actually, in the long run, not help very much. There are some sprays with other components in them that help to keep the nasal mucosa longer. There have been some studies looking at rose geranium and sesame seed oil. I'll talk about that in a little bit. It's a fairly viscous oil that can be sprayed into the nose. It tends to stay for a longer period of time, so you don't have to use it as frequently, which is another downside to some of the sprays that really, to keep your nose moist, you'd have to be using it so frequently, it's probably not practically useful. Ointments have an advantage because they tend to stay in your nose longer and keep the nose moist. Some people recommend using them with an antibiotic. There's some discussion about not using an antibiotic. I think different physicians have different thoughts about that, and probably worth talking to your own physician about that. Most people recommend avoiding ointments with a petroleum base to it. The thought is that if it gets into your lungs, it can cause a pneumonitis or an inflammation inside your lungs. So most people think it's probably best to avoid a petroleum-based ointment. Some of the medications that can be used to help avoid nosebleeds. Think about these in terms of the topical approaches and the systemic approaches. So in terms of topical therapies, we have Avastin or bevacizumab. This is I'm sure many people have heard about bevacizumab. Often it's given systemically for the treatment of certain cancers. It decreases the rate of abnormal blood vessel formation. Estrogen cream changes the surface of the nasal mucosa and makes it less likely to bleed. Topical tranexamic acid. Tranexamic acid is a medication that prevents blood clots from breaking down so that you're less likely to bleed or it will stop a bleed in a shorter amount of time. Timolol is a drop that is typically used for patients with glaucoma but can be placed inside the nose. This has also some effect at decreasing the abnormal blood vessel formation, at least theoretically. All of these things have some smaller studies that show they seem to be effective. The nose study, which was done several years ago, looked at Avastin, an estrogen cream, and tranexamic acid against a placebo, which was a saline spray. And none of those medications showed a significant improvement over just using a moisturizing saline spray. Now, there may be some questions about what dosages were used or how it was given, but to date, we don't have definitive studies that show that these make a large difference for most patients. In terms of systemic medications, we have the antifibrinolytics. Again, these are medications that decrease blood clot breakdown. And so patients tend to either bleed less frequently, or the duration of bleeds are less. The two that are typically used are Amicar and tranexamic acid. These can be used in an acute setting if you're having a significant bleed. It may take some time, an hour or 90 minutes to start working, or they can be used long-term. One of the potential downsides to these is mild side effects, but probably a contraindication for patients who have had problems with blood clot formation. Most people would probably recommend not using it. Doxycycline, I think, is an interesting medication that is gaining popularity in the HHT community. So doxycycline is an antibiotic. It also has an anti-inflammatory property to it. It's been around for a long time. It's really quite cheap, especially compared to some of the other medications that we talk about looking towards the future. The doxycycline is being used in this case for, one, its anti-inflammatory properties, and two, it inhibits an enzyme that lives in the space between blood vessels. And by inhibiting that enzyme, it seems to stabilize these blood vessels for which HHT patients, that means stabilizing telangiectasia, so that they tend to bleed less. And there's some evidence about the use of doxycycline in other blood vessel disease. And some small pilot studies seem to show that it's effective for HHT patients. And I'll talk about another study with doxycycline shortly. Some people are concerned about the long-term use of doxycycline or being on an antibiotic for a long period of time. There are other diseases that patients use doxycycline for months or years, and it hasn't seemed to be a problem. In addition, there's some evidence from the dermatology literature that doxycycline can be used in a low enough dose to get the benefit that we want without having any antimicrobial effect. So if that's true, at a very low dose, you could use it and not have any worry about using doxycycline as far as it being an antibiotic. The other downside to doxycycline is, at least in standard doses, it tends to cause sun sensitivity. So going out in the sun, you have to be careful. Otherwise, you can burn quite easily. Bevacizumab, as I mentioned before, can be given topically. I think more frequently for HHT patients, bevacizumab or Avastin is given systemically. It's given IV. Most protocols require a loading dose of several doses over 2-week periods of time, and then usually a monthly dose, but some patients are able to use it less frequently. One of the advantages of bevacizumab is it has been fairly well studied in HHT, and I think most HHT physicians feel for a large majority of HHT patients, it is very effective. The downside, of course, is you need ongoing treatment, which requires going to an infusion center to get the medication infused once a month or so. Pazopanib is an interesting drug that we've seen some real promise with. Pazopanib is a member of a group of drugs called kinase inhibitors, and it also decreases the formation of abnormal blood vessels. It too has its main therapy as a cancer medication. Pazopanib works in decreasing the production of blood vessels by interfering in several different pathways along the blood vessel formation regimen. So it may be more effective than bevacizumab. We don't know that yet. It's also, the other advantage for pazopanib is it's a pill, so it can be given orally. You don't have to go into an infusion center. There have been a couple of small studies with very promising results. We hope to have a study on pazopanib in the near future, looking at its use in a larger number of patients, and I'll mention that in a couple of minutes. Pomalidomide or Pomalyst is a medication that has typically been given to patients with multiple myeloma. It's similar to a drug that many people have probably heard about because of its history, thalidomide, but has less side effects and is thought to be safer. It too interferes with the development of abnormal blood vessels, and it can be given by a pill. And there is an ongoing study I'll mention in just a moment, looking at pomalidomide or Pomalyst. So I mentioned about doxycycline, and here's just, again, a repeat of those things that you'll be able to read through when you have a little bit more time to look through the PowerPoint on your own. Bevacizumab, again, it blocks what we call VEGF receptors. These receptors are important in the development of blood vessels. It's been shown in studies that patients with HHT have higher levels of this substance called VEGF, so blocking these receptors seems to be quite helpful. And again, tranexamic acid and Amicar can be given acutely or long-term, and for some patients has shown to be quite beneficial. Pazopanib, I mentioned, we're looking at performing a study at its effectiveness for HHT, small pilot studies looking at less than a dozen patients have been very promising, but we really need to look at larger groups of patients to see if it can be beneficial for us. And same with pomalidomide. The PATH study is currently taking place at several centers, several of the centers of excellence, and you can see the criteria if you think you might meet that or you're interested in looking into it on the Cure HHT site. Now, in terms of surgical treatment, just run down a couple of these. I know many patients, unfortunately, have had to undergo surgical therapies for their nosebleeds. Cautery, for the most part, we really tell patients with HHT they should avoid. There's a lot of collateral damage to the tissue, deep tissue thermal injury. And one of the things that we think is happening in patients with some of these treatments is that trauma that I mentioned at the beginning of the talk incites the development of telangiectasia. So when you cauterize or you use this thermal energy to close a blood vessel or a telangiectasia in the nose, it creates damage to the surrounding tissue, and that trauma will just induce more telangiectasia to grow. The same is true of laser to a certain degree, probably, we think. Laser causes less damage to the tissue. It's focused. The blood vessels themselves take up the energy. With some of the lasers that are used, the surrounding tissue is less damaged. But we still think it probably causes some collateral damage as well. Coblation is a so-called cold cautery treatment, and probably less damaging than cautery, certainly. Probably a little bit more so than laser, perhaps, but also causes a little deeper thermal injury than laser. So it does have its place. It allows larger lesions to be treated more easily. So there are a number of ENT physicians who really like the use of coblation for the treatment of epistaxis. Sclerotherapy is a relatively new, lasts several years, dozen years or so, that's been used by some HHT centers. In sclerotherapy, a sclerosing agent is injected into the telangiectasia. So very much like what's done for varicose veins, this sclerosing agent essentially scars down the blood vessel, and it closes. There's probably a little bit more of a learning curve for this, for physicians to really gain expertise in it. There's some theoretical risk. Unfortunately, there's one case report of a patient losing their vision from sclerotherapy treatment, but there have been hundreds and hundreds of patients treated with no real other side effects. It's an in-office procedure, so you can have it done in office and go home an hour later. Unlike laser and coblation, where generally you need to be put under anesthesia for that, and the recovery time is significantly longer with laser or coblation. Septodermoplasty is not used very often anymore. There are still some surgeons who use it. Essentially, the inner mucosal lining of the nose is stripped out of place. A skin graft is taken from the leg and it's placed into the nose. This is probably, for most patients, a temporary fix. The telangiectasia do grow back. The other downside to septodermoplasty is patients experience a lot of crusting, and some say a kind of a foul smell in their nose, and it requires a fair amount of daily upkeep to keep that smell and the crusting away. In Young's procedure, the nasal passages are completely closed. This is used mostly for patients who've tried everything else, or who don't want to have some of the medications we've discussed, or they did not work for them. And it is essentially curative for most patients. Most patients do not bleed again. And we think that's because you don't have the trauma of the air passing by the telangiectasia anymore. So it is curative for most patients. The downside is you do lose your sense of taste and smell, and you become an obligate mouth breather, which can be problematic for some patients. I mentioned embolization as a treatment, as an acute treatment for nosebleeds. This is where the arteries leading to the nose are embolized. Almost always, in most patients, new blood vessels form. So it's not a long-term treatment. It really should probably be reserved for patients who come into an ER setting with life-threatening bleeding that can't be stopped in any other way. So I mentioned a few of these studies. We do have a doxycycline study that is taking place at several centers. Hopefully the results are going to be out regarding the doxycycline study in the relatively near future. In terms of Avastin studies, I hope many people have seen in the newsletter about the Avastin survey that was sent out to a number of places, not just in the US, but worldwide, looking at people's use of Avastin, and it really helped to demonstrate, one, this is an effective treatment for many patients, and two, we're trying to get a sense as to what is the best protocol for Avastin in patients, and that's probably going to take some more time to know, but it was quite remarkable to see the results, not just the results, but the relatively low incidence of any significant side effect where patients needed to stop the treatment. A study that will be coming up in the not too distant future is looking at Avastin and biomarkers, looking at things that we can test for in your blood to see how likely are you to respond to Avastin treatment. We know that some patients respond better than others, and it would be nice to know if we could predict that before giving the treatment and know if the likelihood of success is low, maybe a different medication should be used. I mentioned the pazopanib study that hopefully will be underway in the not too distant future. The pomalidomide or the PATH study is currently enrolling patients. Again, if you look on the Cure HHT website, you can find out more information about the criteria and the patients and the centers that are doing this study. A study on timolol gel should be coming out shortly. This was using timolol made in a gel formation which hardens once it's inside the nose, so there's longer contact with the nasal mucosa. And I think, although not a study looking at treatment, we have a study that will hopefully be coming out, published shortly, looking at severity measurements. So one of the things we really need to know is how well do these treatments work when we're studying them. And we do have the ESS, or epistaxis severity scale, but we're looking at other measurements that can help us look maybe at more day-to-day or week-to-week, shorter-term changes, and know that if we're studying certain treatments, are they really helping patients or not? And then lastly, I just want to mention what I think is going to be a pretty exciting thing, especially for HHT patients. You know, of course, there are two reasons that we worry, mainly that we worry about nosebleeds. One is just quality of life and the social situation surrounding nosebleeds. And the other is obviously the health impact, and we're primarily talking about anemia. And you know, more than 50% of HHT patients are anemic, many of them because of their nosebleeds. So we're partnering with a new startup company, and we're going to be looking, helping them look at an anemia app. And this is exciting. It's going to involve a smartphone, which is actually hopefully going to be able to measure your hemoglobin by taking pictures of your fingernails, and by looking at the color of your fingernails, predicting what your hemoglobin will be. So this is really exciting, obviously, for all of us. If we could measure this, if you've had a bad nosebleed, or you've recently received treatment, or you're receiving treatment, or you just want to know what your hemoglobin is. So we're partnering with this startup company to help look at the app, and please watch for an announcement. We're going to be sending out a survey. We're going to need patients to help us study this app, and we we hope that there's a significant interest in this. If we can help this company get off the ground, I think it will help us all. So watch for that in your emails, social media, and newsletters. So that's all I had for now. Again, I want to thank Chelsea for her participation, and I'll turn it over to her now.
Wonderful. Thank you so much, Dr. Olitsky. I was trying to take notes there too, because I feel like this is important information, and even information that I could use myself as both a patient of an HHT center and as someone who suffers from nosebleeds. So I appreciate your insight. So as a brief introduction to everyone, my name is Chelsea McBride, and I'm 31, and I've had nosebleed symptoms my whole life. I've dealt with a lifetime of other symptoms related to HHT, and when I was 17, I finally got my informal diagnosis about HHT, but prior to that, I had throughout my childhood and into my youth, I had suffered from nosebleeds, anemia, different things regarding my my brain function, like vertigo. I had dizzy spells, lots of things that were unexplained, and then suddenly it was like a lightning bolt hit, and when I heard HHT and the words, AVMs, it was like turning the light on, and I had been in a dark room the whole time. It was very great for my family, great for us to finally have some understanding into what was going on with our family, what was going on with me. Why was I having serious nosebleeds? Why was I constantly, feeling sick or having migraines as a child? There was a lot of things that were unexplained that finally we were trying to see the light at the end of the tunnel come closer to us. And so with nosebleeds, my family had a history of nosebleeds. Both my brother and I have HHT along with my mother, and we all three had nosebleeds growing up. I remember I was the kid who my mom would stuff tissues into our backpacks at school and stuff them into our pockets before we left, and she would be unloading the clothes in the dryer and have, just tissues all over the place, and we slept with tissues under our pillows, or my brother and I both had nosebleeds at night and had to have our pillowcases changed almost nightly because of the extensive nosebleeds that we would have. And I have had numerous surgeries performed. So like I said, when I was 17, I got that informal diagnosis, which took me the route of finally seeking out an HHT Center of Excellence, and that was thankfully due to curehht.org, where I was able to link up with an actual HHT Center of Excellence. At that time, I lived in Utah, so I was able to go to the University of Utah for assistance, and there I got the formal diagnosis of HHT. And there I realized that I had a lot of work to do, that I needed to take control over my healthcare again, and really understand what was going on. So there was a lot of education coming in for me personally, and a lot of catch up that I had to do. So I underwent numerous pulmonary surgeries, coiling procedures. I had 7 performed at the University of Utah, and then I had 2 done at UCLA later. So I've had 9 procedures performed, and I have a lot of hardware in my lungs. I have those coils in my lungs, and that's been a blessing because I breathe better. I am not as winded. So if I get winded, I apologize. That's just, part of being an HHT patient, another symptom. And going along with that, with being winded and things like that. I had suffered from migraines and suffered with, I actually had a brain hemorrhage when I was 17, and luckily that got taken care of and no intervention medically was needed at that time, but then ended up having another one when I was 23 at the University of Utah, got that taken care of there, and they successfully saved my life. So I'm indebted to the HHT centers and the Center of Excellence. I really encourage anyone who is looking for more information, who is searching for good patient care, to really reach out to your Center of Excellence. And that brings me to why I'm here tonight. I still suffer from nosebleeds. I did get in contact when I was in Utah with an ENT there, and at the time it was kind of very low on our priority list of things we had to get done, was looking into my nosebleeds and how often I was bleeding, the frequency of my nosebleeds, and it wasn't really a big risk at the time. So like Dr. Olitsky was saying about the ESS scale, I was very low on the scale, going into a moderate risk of 3 or 4 maybe. And now that I am older and I've had 2 kids, I have seen my nosebleeds increase. And because of that, it's definitely something that I'm trying to keep track of and trying to make sure that I have the tools that I need to make sure that I'm taking care of my nosebleeds. So with that, I wanted to introduce my little HHT nosebleed kit. And the nosebleed kit is very simple. It's great for anybody who has nosebleeds. It is effective for me personally. It's been something that I use on the go. I can have a few of these items in my purse or in the car, wherever I need them really, and I make sure that they're available to me all the time. So Tampax Pearl tampons are one of my huge resources. I brought this out just to show you. You can see the Tampax Pearl tampons, and this one comes with a variety of sizes. And the reason that I think this is important was because I know some of you have questions. What do you do when it's not a serious nosebleed, or when it's not very, it's not flowing out of you, but it's still something that you want to nip in the bud and take care of? This is great because you have a very different varying sizes for a varying nosebleed. And I love that. And what I do, as Dr. Olitsky had mentioned, was making sure that that nose area is, it's so vascular. So you want to make sure that you're not putting a cotton swab up it that's going to be dry, that you're going to end up ripping out of your nose and cause a whole new nosebleed. So for me personally, and for any of the guys on here, there's no shame in grabbing these. So I thought I'd just show you real quick. So this one, take it out of the wrapper, and this is the little dispenser. And for the ladies, I'm sure most of you know how to do this. So the little applicator comes out, and it's in this perfect little plastic tubing. And what I actually do is you can actually run it under cold water, which helps if you have the time to do it. That way later on, you're not ripping dry cotton out of your nose. And I run it under cold water, or if I have the time, I take some Aquaphor and put Aquaphor on that, and just kind of, when it's going up my nose, I'm already coating it and not allowing it to be ripped out later. So you can see I go ahead and just slip that through. The cotton comes out, it pushes through, and very easy for you to use, and comes in the different sizes. So that's easy. As I had mentioned, Aquaphor. So Aquaphor was nice. It's something I pick up. I have 2 kids. It's easy. It's in my diaper bag already. And this is the kids kind. It's the advanced therapy, and it's normally used for diaper rash, but it works great for my nosebleeds and helping to make sure that my nose is being coated versus something like we had mentioned before, like a petroleum. I don't really like just the basic petroleums. Aquaphor works a lot better for me. And then along with that, you can't go wrong with toilet paper, or like a good brand of tissues. That is something I always have. Along with that, let's see, I'm going to go into my little kit here. This is just a simple little Ziploc baggie I have of Q-tips. The Q-tips help because later on, if that nosebleed has resolved, I can take a little bit of cold water and like clean out the crust very gently and do that. So that is nice for later. Or if you, you know, are noticing that you're having one, but it's not really bad, maybe it's just a light drip, take one of these, run it under some cold water, and, you know, apply that pressure into the area. Also, you could just do an aquaphor, put a little bit of aquaphor on the tip and gently moisturize that area. If you feel like it's a dry day outside, that's not a bad idea. Also, if I'm going to the ER, because I have pulmonary AVMs, I'm bringing my micron filter, and I have gauze. Those are just a couple things that I have. I also have a dark change of clothes or a dark t-shirt because that's easy for me, and I have my medication. Really simple, something you can grab. It's on the go, it's easy. It should be in an emergency kit or your own type of emergency kit for you. So with that, as I said, I had suffered with anemia and different things, and trying to get back that control over my life, I wanted to make sure that I was able to control my nosebleeds better, to make sure that I wasn't anemic. And now that I have better control over that, I can mark it in my phone. I was using the Cure HHT app, or you can simply put it into your phone. The time, the duration, I would also put in how long, you know, it lasted from beginning to end, and even like I would even count the time that you have the pressure in your nose until it's completely resolved. Other than that, there's a lot of things that you can do. I know a lot of people have mentioned putting ice on the area. That is something that you can do, or a cold compress. Those help as well. And I've tried a combination of things like that, but definitely knowing what you're up against as far as a nosebleed absolutely helps you to help yourself, and that way you're not caught off guard. So with that, I'd love to turn the time back over to Phyllis, and if we have any questions.
Thank you, Chelsea. That was great. So we are going to get to some of our questions. We did have quite a few that came in prior to tonight, so we're going to try to tackle some of those. And I'm going to start with a question that came from Barbara in Massachusetts. And she's asked some of the things that I think both of you may have already touched on, but if we can address it, that would be great. She said when she has a bad nosebleed, is it better to let the nose bleed into a cup versus putting something inside the nostril, or to apply pressure on the outside of the nose? She said her ENT advises using aquaphor, just like you said, Chelsea, around the inside of the nostrils. But what do you think is the better way to manage that?
Right. So as far as it goes for me, if you're not in a dangerous situation and you're curious how much you're bleeding, then that might be okay to put it in a cup. But for me personally, I want to nip it in the bud, as I said, and I want to apply pressure right away. I don't want this to get out of hand. So I try and apply the pressure, put the tampon in, and take care of it. Now, I don't like the smell or the taste of blood going down my throat, and I want to take care of it.
So when would you know if a nosebleed becomes kind of monstrous, as she's describing some of her nosebleeds? How would you know when you need to go to the ER? Dr. Olitsky, can you answer that? Or
yeah, and just to touch on what Chelsea was saying, you know, most of us suffer from anemia. I'd be hard pressed to say that you should just let your nose bleed. I think holding pressure on it, sometimes what I hear people doing is, you know, they hold pressure low on their nose, but it's bleeding is just going back. So you're not getting a lot of help with that. Sometimes when people can't stop it, you know, they aren't putting whatever cotton or a tampon, high enough or with enough force sometimes to make it stop. But when I get my blood drawn, I ask them to use the pediatric tubes if they can. I don't want to lose anything. So I would have a tough, I think, I can't imagine a time where I would tell a patient, just let your nose bleed. So when should you go? Well, sometimes that's a tough question. That nosebleed that just doesn't want to stop. And especially if you are somebody with who's anemic with a low hemoglobin, your threshold should be lower than somebody who knows their hemoglobin is 13 or 14 perhaps. So I think that certainly has to play a role in it. And I would say when your usual things can't stop it and you continue to bleed, you should think about it. Now, having said that, most of us know how to stop a nosebleed better than most people in an emergency room do. But they do have other things. They have balloon devices. They have posterior packs that they can put in. So there are other things that they can do. But I think a lot of it's a judgment call. It's a very personal call. But I think your hemoglobin status, as well as what if you've exhausted the things. For some of us, it's pressure first. If that doesn't help, then you put something in your nose. And the other thing I think people tend to do, at least I think some, is they put something in their nose and take it out 5 minutes later. That's probably not enough time. And all you're doing is just letting it keep bleeding. So, there have been times where I've just gone to sleep with my nose packed. I've tried for a while and I've been able to get it stopped, but I can't get it unpacked. So I just go to sleep. And I think we've all had those experiences.
Thank you. Well, that also leads into one of the questions that someone was asking this evening, and I just thought I'd go ahead and skip over and ask that one is, are there any key words or trigger words that you can use when you get to the ER so that an emergency room physician who maybe isn't as familiar with HHT, it might help them understand more? Like how can you describe, what can you tell them to help that experience go smoothly?
I think a couple of things. One is certainly you can tell them what your disease is. Fortunately, nowadays, everything's on a computer. So physicians who may not be very well versed can easily Google it, go to our website, and become familiar with it within a matter of minutes. But I think, explaining to a physician or a healthcare personnel who isn't familiar with it, what the nature is that you have these abnormal blood vessels in your nose that bleed. And I know we've all gone through this. Some people can't really believe that your nose can bleed enough to become anemic or have to go to an emergency room. But fortunately, there are resources on the internet that people can access pretty easily.
Great. So some people were asking about different foods, and that's a whole other topic, things that trigger. But one of the questions that came up a couple of times is, are there vitamin supplements that might increase nosebleeds to also be aware of?
So I think two that are pretty well described, and I know lots of people talk about triggers, and everybody has their own experience. But if we're going to talk about things we know and there's scientific data about, garlic and ginkgo biloba. Those two things in the surgical literature clearly have an effect on blood clotting. So those two vitamin supplements, I would think about avoiding those, especially if you've used them and you've had increased bleeding. And many surgeons like their patients to avoid them before surgery. On the other hand, low vitamin D levels have been linked to more significant epistaxis. We don't know that for sure, but certainly most Americans are low in vitamin D, so making sure your vitamin D levels are appropriate and taking vitamin D if needed can't hurt.
Yeah, getting out in the sun a little bit, getting some
That would be a good thing.
Now, I know you mentioned, and Chelsea, you mentioned too, about the petroleum-based products. Vaseline is one of the brands. Some folks are asking questions about what other types of ointments. Chelsea, you mentioned Aquaphor. There's some others that you know of that people, if that's not accessible, there's something else that they can use.
For me, other than that, I think they'd have to search. I'm sure it'd be easy enough to search their local like Target or or Walmart and see something that's similar to Aquaphor that they can read the ingredients that doesn't have like a petroleum base in it, that would be easy enough.
Yeah, I don't know offhand. I agree with Chelsea. You can search those. Although a lot of physicians have a theoretical concern for it, I'm not sure how often it's been documented in HHT patients. Aquaphor is a good medication. I've certainly used it at times, but there are probably other ones that work as well without the petroleum as too.
So you mentioned earlier about the rose geranium oil compound, and we had some folks ask us the question about being able to access that. So a lot of them had said that they were having trouble finding it at the local pharmacy, or the pharmacy didn't have the compound. Is there a recommendation of where they can purchase that? I thought at one point Mayo Clinic might have had, you could order it from them.
Yeah, I know Mayo Clinic does. I think a couple of the centers have compounding pharmacies. You have to get it at a compounding pharmacy. Many compounding pharmacies, if you tell them about the product and maybe give them one of the reports that's been published, they may very well make it for you. O'Brien's Pharmacy is a compounding pharmacy here in Kansas City. They've done some work with us for Pure HHT on some of our scientific studies. They ship all over the country. I don't have any financial tie to them, but they can certainly do that as well.
And I know we do have the compounding formula on our website, so people can download it and print that out and take that to a pharmacy. So our next question is, we've gotten several questions about sclerotherapy, and is it recommended, and are there any plans to do more research behind it, and what HHT centers are offering that option?
So it is, I think, a treatment that a lot of people who have used it would say is very effective. One of the advantages, as I mentioned, is that it's an in-office procedure. You don't have to be placed under anesthesia. You go home as soon as it's done. Your nose is a little stuffy, maybe for a day or so. It probably, we don't know, but it probably creates less collateral damage to the tissue. And I hear, and people ask about studies. There's a lot of published information about sclerotherapy. We know about some of the theoretical risks. As I mentioned, there was one very unfortunate case of a loss of vision in one eye from a treatment in one patient. To this date, I don't think we know of any other patients. But when we talk about studying these, to study this in what I think most physician scientists would say is a rigorous fashion, you really have to essentially do a sclerotherapy study in some patients and inject other patients without any medication. And I don't think we're ever going to see that type of study. Whether or not we'll see a study comparing sclerotherapy versus laser, again, you'd have to have patients who come in and want to be randomized to one or the other. I don't know that we're going to see that. It's not that we wouldn't want to see that information. Those studies were prospective randomized studies in surgical treatments like this are going to be very hard and maybe impossible to do. What we will see is retrospective studies. We'll see physicians reporting on the usefulness of the procedure. And over time, we can say this has improved the lives of so many people. It's unlikely that this just happened by chance alone. So I don't know if that answers that question, but I would say we're probably not going to see some of the studies that we might see in cancer therapy studies and things like that.
And I know on our website under our HHT resources where our centers are, many of the centers have listed that are offering sclerotherapy is listed as a treatment option at their center. So people can go on to the website and look that information up to see which HHT centers are offering it.
Yes.
So I had another question from Dave, and he wants to know, he said he has allergies which cause sinus congestion, and the sinus pressure in his nose causes blood vessel rupture. We want to know if using allergy medicine like Claritin D to clear up the sinuses, is that a good solution? Is that okay to use?
The problem with some of these medications is it tends to dry your mucosa out. And when you use these allergy medications and your nose gets dry, it's more prone to bleeding. So I would say if you find yourself in needing to use it, you should probably take extra caution to keep your nose moist. Local therapies might be better, and even topical steroids might be helpful. There's an inflammatory component, we think, to telangiectasia formation. So patients with allergies may respond even more so by treating those allergies with a topical corticosteroid medication that you can now get over the counter.
Okay. We had a patient ask the question. They said that their ENT is suggesting tamoxifen orally. What is your opinion on that? Have you heard about that, or is that another option?
It is an option. Again, it's not a well-studied option, but there are some smaller studies, retrospective, meaning patients took it and they say they got better. But there are no studies looking at tamoxifen versus getting a placebo pill and seeing, was this just a change in your bleeding cycle versus did the drug have a real effect? But it is an option, and some patients seem to have had a positive impact using it.
Chelsea, I'm going to direct this question to you. I have a couple ladies on here who are asking about, you mentioned that you had 2 children, and they're interested in knowing if you experienced an increase in nosebleeds during your pregnancies.
So I did notice an increase of nosebleeds during both of my pregnancies. I think my second pregnancy was worse. And that could just be a number of factors. We've moved, we're in a different location, different weather, I'm older, and each time it's different. But with each pregnancy, because I think we all know that your blood volume increases when you're pregnant, and because of that, I just saw an increase of my nosebleeds. There's hormones, you're creating a human. So there was, a lot of strain and pressure, I feel like, on my system personally. And because of that, the nosebleeds did go up. In my first pregnancy, it wasn't a severe risk, and I dealt with them, pretty moderately, as I had mentioned. And this second time around, it was a lot worse. I will say that the second time really threw me in for a doozy, where I saw myself in the ER a couple times, and for nosebleeds that just would not stop. So.
Okay. And what about menstrual cycle? I mean, Dr. Olitsky, is there any studies or evidence showing that women experience greater nosebleeds before or during their menses?
No studies that I know of, but we hear anecdotal evidence that that is the case.
Okay. Yeah, we have a couple people asking that same question. So what about, some people are asking about nosebleed severity increasing with age. Is there any recommendations as people get older, things that they need to change up? What are you
Well,
saying?
I think all of the things we talked about to help. It might be, think about moisturizing your hair, maybe moisturizing your nose. For some people, it might really mean look at the environment you live in. There are certain places, high elevation, very dry climates. That might be a place that's harder for some people to live in. And it may be that a change of environment would help. But I think as you get older, each of these things, you may need to escalate the type of care that you need to give yourself to prevent your nosebleeds from getting significantly worse.
Great. So I have a question from Marky in California, and they're asking how effective is bleed arrest ER at stopping a bleed? Do you know if there's any discussion on that, or that the use of that?
I have not used it myself. I haven't heard of any discussion. Maybe Chelsea has used it. I don't know about that product specifically.
And I'm sorry, what was it again?
Bleed arrest ER.
I haven't heard of it or tried it, unfortunately, but it's, something everyone should look into. And with all of these different, like Dr. Olitsky had mentioned, it could be a number of factors, so a number of things might be able to help.
We're trying to get through a couple more questions. We're getting close to the 8 o'clock hour, but we just have a few more here. Are there any results? So there was a doxycycline, you mentioned it as one of the treatments, the antibiotic doxycycline. It's been around for a long time, and there was a study done, and we have patients that are asking if there were any results from that study and what was the trial dosage and the duration of the treatment.
So I don't recall the duration exactly. The dosage, I believe, was 100 milligrams twice a day. I think I don't know if any patients went to less than that. So some patients outside the trial use 100. I mentioned it can be given in lower doses at 20 milligrams twice a day. It doesn't have the potential antibiotic side effects, but the study was 100 twice a day. I believe the last patient was just recently enrolled, finished their enrollment, so they have to follow that patient out, and then we should hopefully have results shortly.
Great. Okay. And then I have one other question, my last one from Victoria. She's saying she's 41 years old and her bleeds are about 3 times per week. Her father's had multiple surgeries to try to help his nosebleeds, and they have never been that effective. What can she do now that would be effective? And you've touched on a lot of those, treatments versus, surgeries. And she wants to know what she can do to help her younger children, if it's possible to stop the formation of bleeding vessels. Is that possible? Any preventative care?
So I don't know that we know that there's any way to prevent those blood vessels from developing. In younger children, obviously, we want to be a little bit more cautious about medications, especially systemic medications. In older children, other medications may be useful. I know some people have used the timolol drops in younger patients, teenagers, who have mild to moderate bleeding with some success. But again, I think moisturizing humidifier is an easy thing that can help, especially in a very dry climate. So I think, as you mentioned, there's that list of things that you start with: moisturizing the nose, and then moving down the list as needed.
So I'm going to end on this question because we've had probably a dozen people ask it. And the question is about the nasal swab for the COVID test. How a lot of people are concerned if they have to have the test, is that going to create a bad nosebleed? They've seen pictures of the testing and they go far up into the nose. So there are concerns. And is there an alternate test that's just as effective?
Yeah, so I think here's a case where you have to weigh risk and benefit. How easily do you bleed? How severe are those bleeds? If you're the type of patient who is just wondering if you might have the virus and you're not going to do anything different, you would home quarantine yourself regardless because somebody else in the family had it, and you bleed easily with severe nosebleeds that get you sent to the emergency room, you might want to rethink taking that test unless it were absolutely necessary for some reason. Right now, I don't think saliva testing has been rolled out to any significant degree. I think that is hopefully going to be an option. It'll be a more rapid test and you'll be able to spit into a tube. I think it's available in some locations, but I don't know that for sure. And it's certainly not widespread right now.
Well, thank you, Dr. Olitsky, and thank you, Chelsea, both of you, for your insight and your guidance. Unfortunately, time doesn't allow us to answer all of the questions, so you can look at our website at curehht.org and our resource library. You probably could find most of your questions or answers to your questions there, and we will also be following up with those resources as well. Our next upcoming virtual meetup with Ask the Doctor, we will be focusing on the subject of anemia, which will fit in great with this new app that Dr. Olitsky mentioned earlier. And that would be the subject of our next one. And then we also are going to do a virtual meetup within the next couple of months with 3 of our HHT physicians from our centers to talk about COVID-19 and what every HHT patient needs to know about that. There's still a lot of questions out there surrounding COVID-19 and how it relates to HHT, and we want to make sure our patients are receiving the most current and up-to-date information as we continue to battle the pandemic as a community. And again, we do put updates as we receive them on our website. So on behalf of everyone at Cure HHT, thank you for attending tonight's virtual meetup and for staying connected with us during this unique time in our history. Cure HHT is the only patient advocacy organization in the world for HHT, and we are here for you. The entire HHT community of patients and families and healthcare providers and researchers, and you can rely on us to answer questions, provide timely updates, and offer support through COVID-19 and beyond. Our shared goal is to advance one common hope, to give those affected by HHT a chance for a normal life, and our virtual meetups and webinar series are just a way of helping us accomplish that mission, and we are grateful to the donors to Cure HHT for making this and all of our educational opportunities possible. Please consider donating to Cure HHT to ensure we can continue to offer high quality education for you and your families. And you will receive an email after this webinar with a short survey. Please take a few minutes to give us your feedback. Your input is critical for the development of future conversations and future virtual meetups. Remember that many of our previously recorded webinars and some of our Ask the Doctor virtual meetups can be found on our website. And again, I want to thank you, Dr. Olitsky and Chelsea, for volunteering your time to host this virtual meetup. We truly appreciate your participation and hope that you enjoy the rest of your evening. Thank you.
Thank you.
Thank you.